Hello, everybody. Thank you for the invitation to speak here today. I'm going to be talking about the use of AI to improve access to radiotherapy across the world. Some conflicts of interest. So Guha just talked about, in his opening slide, talked about the lack of access to CT scanners. I'm going to take that to the next level and talk about the lack of access to radiotherapy. This is just a background slide. We're very used in America and much of Europe, about 50% of patients, cancer patients, will benefit from radiation therapy. And we're pretty used to being able, access is pretty good for us in North America and high-income countries. That's not the case in most of the rest of the world, and that's what this figure is showing here, where the different colors indicate the percentage of patients who could benefit from radiation therapy who actually have access to that treatment. And you can see that in many countries, especially in Africa, less than 50% of patients who could benefit have access. And that's particularly bad because it's estimated that by 2040, which is really just around the corner, about 70% of annual cancer cases will actually be in those countries. There's lots of reasons for that, as you can imagine. One of the big ones, or one of the things we need to do to resolve that, is to address the massive shortage of professional staff. So we need radiation oncologists and medical physicists, both of whom go through graduate school and residencies and sort of extensive training. And then also, as well as just access to radiation therapy, it's not just being able to get treated. You want to get treated with high quality radiation therapy that limits the toxic effects of the treatment. And a study, for example, in Africa recently showed that the places that do have radiotherapy centers, only about a third of them are using what we would consider to be standard of care treatment planning. So that means that that's going to have an impact in terms of outcomes, in terms of tumor control, and also in terms of the side effects. And then if that's not compelling enough, it's estimated if we could close this gap, we could save nearly 1 million lives per year. So that's the background. So why do we need all of these staff for radiation therapy? Well, it's really big. It's a very time-consuming, complex process. This figure here is supposed to try and show you a sort of big view of all the different tasks that have to happen, all the different people that have to be involved. So just to run through it briefly, we start with the diagnosis and evaluation by the physician. Once we decide we're going to treat somebody, we take a CT scan of the patient in the treatment position. The physician decides on the dose. They then, even today in 2022, physicians typically then go onto the CT and they draw around, typically by hand, what they want to treat, and then they also draw around everything they don't want to treat. That can take several hours. Once that's done, they pass that information to the planner, which here we have people called dosimetrists. In many countries, it's the physics staff or maybe residents or clinical staff who do that. And their job is to decide which directions the radiation should come from, what intensities, how are you going to vary the different intensities, that sort of thing. And they come up with a plan which they think is reasonable. They present that to the physician. The physician wants some changes for their particular patient on the third row. And there's sort of an iterative process as they go backwards and forwards and eventually come up with a plan which is approved. And then after that, there's some QA tasks that have to happen. Typically, you would take the plan, you show it to your peers in terms of physicians to make sure they agree on the treatment, and also some physics QA and other QA. So there's all these processes, lots of handoffs. And lucky for us, we're alive today, quite honestly. So most of this can be done with AI. So the contouring can definitely be done. A lot of the planning, I'm going to show examples of these, a lot of the planning can be done with AI. And if you do this in a consistent, predictable, and high-quality way, what that means is there's less iterations in the third row. So the plan that comes out is generally pretty good, and you don't have to keep going backwards and forwards, which can take many days, actually. And then you can also support the peer review and the automatic QA. And so the impact of doing that is, I've tried to show it here, it's difficult to show, but basically you shrink all of those tasks, you reduce handoffs, and you reduce the amount of work that the human has to do. You can save time, reduce handoffs, you get gains in safety and quality, and also a lot of gains in consistency. So if you go and get contoured and treated by this person, you'll get the same answer as you're treated by somebody else, which is something that often doesn't happen today. Okay, so now I'm going to give you some examples of where we are. So contouring, the physician draws the tumor. They also draw all of these normal tissues. They have to do them individually because each one has a different tolerance to radiation, so we have to understand that. Here we've got pretty straightforward auto contouring, where one of these is the manual contour, one is done automatically. You can guess in your head, but the one on the right is the AI-generated contour. And the point here is that they're very, very similar. You can see some subtle differences here and there, but they're not going to make any impact clinically. And this is a tool that's in use in our own clinic today. That's the contouring. Once you have all the contours, you then have to do the plan. Here is a similar thing. The way you read these plans is that the shaded red area is what we want to treat, and then all those different colored lines represent different dose levels. So we're trying to get the high dose to the target and reduce dose to everywhere else because we want to do as little damage as we can to the patient. One of these is automatic, one is real. In this case, the one on the right, again, was the automatic. You see they're very similar. We showed these to the radiation oncologists. They like them both. The one on the left is the original clinical plan, and then the automatic one they had a slight preference for because of better conformality of the treatment, but basically they liked them both. So once you've got the plan, the next thing is for somebody to review it. And you can imagine if you're in a country that doesn't have much radiation therapy, if I'm the head and neck radiation oncologist and I'm not really sure if it's a good plan or not, normally here I would go and ask my friend, like at MD Anderson, where I think we have 10 head and neck radiation oncologists. In many countries, there's only one. So what do you do, and how do you get used to this type of treatment? So this is another place that AI can really come in because we can tell you what a good plan should look like. And so we've been working on this where we take the contours and the CT and we predict using deep learning what a good plan should look like. And so here we have the same sort of plan, just different views, where one of these is the AI plan and one of these is an original clinical plan. In this case, the bottom one is the predicted plan. And so the way you could use, there's lots of different ways you could use this tool. One is to really help radiation oncologists who don't have the experience, or treatment planners who don't have the experience, to understand what a good plan is, because it's not that straightforward. And here's just some examples on this screen where the top plan is the original clinical plan from a clinical trial from various institutions, and the bottom is the optimal plan. And the idea here is to show that there's lots of different ways that you can create a not quite optimal plan that seems okay on the face of it, but it's not. So like the top left one, you can see my mouse. Here is there's a lot of dose going to the back of the neck, which doesn't have to be there. Here we have a lot of dose outside the target, so it's not a very conformal plan. And here we've got a lot of hotspots, which can give you unnecessary toxicity. And so, but if you don't know about these things and you haven't had the training, you may not know. So that's where the AI can come in to help with training. That's the peer review part. You also have to do some checks because radiation, we can do a lot of good. We can also do a lot of harm if you get it wrong. And so you want to make sure that everything is checked properly and is correct. You check the contours. So in the left, we're doing a sort of brute force approach to that, where we contour automatically twice, with the idea being that if the two independent algorithms agree, then it's probably a good contour. If they disagree, one of them's wrong, we would flag that to the user and say, hey, pay attention to this, something's going on. And that's what you can see on the left for the parotid contours. And then on the right, this is for a very simple radiotherapy case. So very simple radiotherapy is like a shadows game, where you're basically trying to block out the parts that you don't want to treat. This is the field shape for when you're treating cervical cancer. We've got two apertures determined, both done with AI, but different approaches. We've got a red aperture and a dotted yellow aperture, and you can see in one case they agree and in one they don't. So then we bring that to the user and say, look, something's going on. Please pay extra attention to this patient. In terms of deployment, we've deployed a lot of these tools in our own clinic. They're used for about 100 patients a week right now for a variety of different things. And our real goal of our group is to take those tools and deploy them elsewhere so that clinics in lower middle income countries can take advantage. We've created, with the support of our institution, we've created a web-based service which will offer this range of different contouring, simple planning, complex planning, so that the local clinicians can go and sort of choose how they want to treat based on their own resources and their own individual patients. We've submitted this for regulatory approval. We should hear soon, fingers crossed. And this is our plan, is to deploy this, starting in South Africa, where we've got really good partnerships, and then moving beyond to Tanzania and other countries. Again, fingers crossed. But hopefully we'll be deploying starting early next year. So thank you again for inviting me. This is just members of our group and all our collaborators. I didn't really talk about all the different data sources, but it is important, of course, to have data sources not just from Houston, but also from where you're actually trying to deploy these tools. And so that's why we've got partners across the world. So thanks very much.
Thank you. We have time for 1 or 2 questions.
Down here.
So you mentioned the lack of trained experts in some of the less fortunate countries. How much of the problem is because of the lack of equipment?
Yeah, so yeah,
That's expensive, right?
there's a lack of equipment too, but there's one of the human resources is the real sort of bottleneck on this. So equipment is expensive, but once you've got the money, you can buy it. And so if you go to a clinic like in Botswana, for example, it really looks the same as a clinic here in Katy. It's got the same sort of equipment, but there's a real lack of people. And so often there's like big waiting lists. Like in Tanzania, who are really good partners of ours, they just to get treated, they often have like a year waiting list. And it's really because of the human resources, not, I mean, equipment is, don't get me wrong, more equipment would be terrific, but it's the human resources. And it's not just, I just talked about the planning side, because that's what we focus on. The treatment side too, there's lack of resources for the technicians who actually treat the patients. You hear stories, even in South Africa, which is relatively well-resourced, of machines being mothballed because they don't have enough technicians to do the treatments. There's just not enough people.
Wow, thank you.
Yeah, you're welcome.
Let's thank Laurence again, and then hopefully you all get to ask more questions